Hi, welcome everybody to another session for our CME on Saturday afternoon, presented to you by SJMC Cardiology team. This will be the 19th Grand Rounds, and it's part 2 of atrial fibrillation, new weapons against an old enemy. So before I hand over to the chairman, Dr. Kanan, let me just take you through some housekeeping. As usual, we would like you to ask questions using Slido. So in your phone, you can open the browser and go to slido.com and enter the code 360331, and that will take you through the Q&A section of Slido. You can also scan this QR code to be taken to the same link if you like. If you have the Slido app, you just enter the code 360331 and it'll take you to our meeting. Okay. If you are viewing on YouTube or our DOPS Facebook, you can ask questions there, but we shall prefer if you use Slido, please. Okay. Now, the QR code for claiming CBD points using the MMA app will be presented at the end of the talk. So stand by only at the end, okay? And we'll display it in the slide here. So without further ado, I'm going to show Dr. Kanan's slides, and I'll pass over to Dr. Kanan, who is chairing the meeting, and I'll remove myself from the view. Okay, over to you, Kanan.
Thank you, Alan. Thank you for the introduction. Welcome, friends, ladies and gentlemen. I'm going to jump straight in because we got two interesting cases to share with you. One person whom we have been looking after for the last 17 years. So we'll start with case 3. Because we have done case 1 and case 2 during part 1. Case 3 is a gentleman we've been looking after since 2005. He was 46 years old when he was first seen in November 2005. He presented with a 1-month history of lethargy, effort dyspnea, and cough which had worsened for 3 days prior to admission. And this time there was also symptoms suggestive of orthopnea. He also had noted some intermittent fever. So on the day of admission, he sensed a fast heartbeat, and he had been well in the past. Medical exams in 2001 and 2002, which included treadmill assessment, was said to be normal. He did not smoke, there was no history of diabetes or hypertension, and there was no chest pain. Clinical examination revealed a very unwell person. He was tachypneic. The jugular venous pressure was markedly elevated. Clinically, there was no fever we could detect, no edema. The peripheral pulses were very weak. Blood pressure was just 70, and that by palpation. Even now, I can remember that we could not get his blood pressure to the usual measurement. In the heart, we are unable to feel the borders. There was S1, S2 heard, no murmurs. Apex rate 170 per minute, completely irregular. Lungs were clear. The abdomen, he was tender all over. There was a lot of bruising, and he said this occurred after he had gone for a vigorous traditional massage to cure him of the symptoms. No organomegaly that I could feel. Bowel sounds were well heard. So the first question goes to our expert, Dr. Koh. Based on the clinical exam so far, what would your differentials be, Dr. Koh, and what investigations do you think we should do?
Thank you, Dr. Kanan. Very interesting case. Now, any patients that presented for the first time with a tachycardic pulse, the pulse rate is very fast and irregular. The clinical diagnosis is almost always the fast atrial fibrillation or atrial fibrillation with a rapid ventricular rate. Now, atrial fibrillation can comes as a primary cause or secondary, means that secondary to something. Most commonly is triggered by infection or sepsis. And sometimes it can be hyperthyroidism, post-myocardial infarction, triggered by heart failure, so on and so forth. Now, in this case, where the patient clinically had atrial fibrillation, BP a bit low, intermittent fever, we are worried about more of a infection. Infection can be anywhere from the source intra-abdominal, even if you have so like florid sign, low BP, sometimes one of the differential will be possible myocarditis, cardiogenic shock. And the investigation definitely is to tease out what is the secondary cause. We will send for cultures. We need to send the usual full blood count, renal function, liver function. Of course, to get the diagnosis in, we need the echocardiogram and the 12-lead ECG. That will be the preliminary investigation I will do.
Thank you, Ko. So this is the only piece of investigation I could salvage from 2005. Everything else had either disappeared or too faded for me to reproduce. So I think everyone will agree that this shows atrial fibrillation and that the ventricular rate is fast. So this is a chest X-ray. They showed cardiomegaly. There was some upper lobe diversion of blood vessels to indicate that the left ventricular end-diastolic pressure was high. The rest of the lungs was clear. We did echo, as Ko said we would do, dilated left ventricle, very poor left ventricular systolic function. We estimated EF, we are at 20%. The heart valves were normal. Now we did some blood, and you can see that the urea and creatinine is certainly elevated, and the liver enzymes are really across the roof. Thyroid profile was normal, hemoglobin was good. So Dr. Ko, to you again, can you explain to the audience why there's impaired renal function and why the liver enzymes are so elevated?
Okay, and so the most common cause in patient that is unwell with a low systemic blood pressure, they can cause what we call a hypoperfusion, not only to the brain, sometimes to the kidney and also to the liver. This causes ischemic hepatitis and also we call it a pre-renal failure or acute kidney injury secondary to low perfusion. If we improve the perfusion, meaning that if we increase the blood pressure, you can see that the renal function and liver function will also improve accordingly. Of course, second thought is whether there's any sign of infection that causes liver enzyme to be raised, like liver abscess, for example, may need to be investigated later on if the patient still has persistent abdominal pain.
Okay. Thanks, Ko. Just to our thoughts too, the patient was also severely uric. He had a lot of metabolic acidosis, which we thought was due to poor perfusion or the lactic acidosis. The blood gases were normal. So, Dr. Choi, how do you think would want to treat this patient, and would you perform emergency electrical cardioversion as most of the guidelines would advise in someone who presents with low blood pressure and very fast atrial fibrillation?
Yeah, thank you, Dr. Kannan. Hold on, please. Can you hear me?
Yeah.
Yep.
Yes, very good.
Okay, sorry. Yeah, thank you, Dr. Kannan. The question. I think the most important thing we are dealing with fundamentally now is a patient with a very fast AF, cardiogenic shock with multiple organ hypoperfusion. So the first thing I would like to do is actually to stabilize the patient first. Putting him on some kind of inotropic support to bring the BP up, to buffer and dampen the further hypoperfusion. He has a little bit of metabolic acidosis. I'll try to correct the metabolic acidosis, perhaps with a little bit of sodium bicarb. That's the first thing. And then in terms of the heart rate, we can put him on some kind of anti-arrhythmic drugs or maybe even a low dose rate limiting drugs to control the heart rate, but that will probably come secondary given the fact that his BP is quite low. Now, the interesting question is, would I prefer perform an emergency cardioversion. So I'm quite sure that when we are reading up the textbooks, it's always ideal to say when the patient is in shock the patient, without any doubt. But slowly, in my own ways, I learned that it's not always true. The few points I would like to share is, number one, if we shock the patient who is very ill, the BP barely palpable, pulse barely palpable, EF of 20%. So what's going to happen? You can't just shock the patient. You have to sedate the patient. Sometimes even after sedation, the BP will drop even further. And another thing is sometimes you shock the patient. Yes, the patient may go into a sinus rhythm for a while, for a couple of seconds, and get reinitiated back into atrial fibrillation. So you'll find that your effort will be futile. Shocking the patient will also cause quite a bit of myocardial stunning. So the EF of 20%, maybe you drop to 15% or even lower, and you'll end up intubating the patient just to make the patient a bit more stable. So you spiral down. So my take is, I would prefer not to cardiovert the patient. He's still conscious, he's still alert. I will just probably stabilize him with the drugs I mentioned earlier, in addition to a bit of anti-rate control. That's for my opinion.
Okay. Thank you. I mean, all the concerns you shared was what we worried about in 2005. So we elected not to cardiovert him. We thought our experience with trying to cardiovert patients who are this ill generally has not been good. The patients end up with, you might have to do CPR. So what we did was we gave this gentleman dopamine and dobutamine to prop up his blood pressure. We gave him amiodarone to control the rate and hopefully get him to sinus rhythm. And we thought we needed to correct the acidosis. We gave him bicarbonate. And especially after the bicarbonate, we found that the patient starting to improve very fast. Hemodynamics got better, and over the next 1 or 2 days, the liver and renal profiles progressively normalized. And 24 hours after he was admitted, he reverted to sinus rhythm, and we could tail down the inotropes quickly and stop it. And Dr. Choi, how do you think you would manage this patient henceforth? Now his sinus rhythm, blood pressure is back to normal, and what should we do?
Okay, so a little bit more about the pharmaco part. Now that his sinus rhythm, I will maintain him on some kind of anti-arrhythmic agent. We have used amiodarone and seem to work well on him. I'll put him on oral amiodarone for now because we don't really know the underlying cause of his AF yet. Plus minus with a little bit of beta blocker if the BP is okay. That's the first. Secondly, we need to investigate why he developed atrial fibrillation. The commonest causes will be, number one, ischemic heart disease. So I'll probably do a bit of an ischemic study or maybe a CT scan of the coronaries or even an angiogram to figure out whether there's any ischemic drive towards the AF. And to further monitor the patient, I'll put him on a Holter. We can go up to 7 days. Oh, in fact, we have this Holter thing. It can go all the way up to 14 days. So you can actually place it onto the patient's chest, and the patient can wear it, and we can see the AF burden or the trigger burden that the patient could have, even after discharge. The patient can shower with it. One interesting question I would like to ask back, Dr. Kanan. What do you think of the role of anticoagulation in this patient? I'm sure a lot of people out there, they say, oh, this patient had AF, right? EF was a little bit poor. Yes, he's about a bit youngish looking, not more than 60. Do you think there's a role of anticoagulation for this patient, Dr. Kanan?
Okay. Now we must remember that this is 2005, not 2022. So some of the toys you mentioned, that 7-day Holter and 21-day Holter was unheard of in that time. I think even Holter was considered a rarity and only certain hospitals had it, and Subang was one of them. So that's number one. Number two, coming back to the diagnosis, when I saw this man, my thought was this is myocarditis. He didn't have any of the other reasons why he could develop atrial fib. There was this little bit of fever, and then things started improving very fast as did his LV function. So I did not think of putting him on anticoagulation. And anticoagulation in 2005 was totally warfarin. So since he went to sinus rhythm and LV was improving, I didn't want to increase any risk of bleeding. I still did not think that his atrial fib was going to come back. I thought it was just going to be a one-off thing and to be cured for the man. So let's go on. So this is what we did. So carvedilol was already available. The moment the BP was a bit better, we introduced carvedilol. And in 2005, carvedilol was considered like a magic drug. It just come not too long ago. And because his renal function was not very good, we did not want to use an ACE inhibitor or ACE receptor blocker. So we initially gave him a little bit of prazosin to offload. And then during follow-up, when the kidney had completely gone back to normal, he was started on some ACE inhibitor. So once he got better, the patient said he didn't want anything more done. We certainly wanted to get his angiograms done to see if he had coronary artery disease. So he went home. Now 3 weeks later, he continued to be well and asymptomatic. We did an echo, and the echo EF was completely normal. So Dr. Koh, if you had been following up this man, and retrospectively we were trying to think what could have happened to him a few weeks ago, what would you attribute the cause to be in November of 2005?
Interesting. So this is something that rapidly improve with some medication. I'll agree with you that probably there's some initial insult for this patient initially, some form of infection like viral myocarditis that triggers into the AF heart failure, which of course self-limiting. If not, he probably will even progressively worsen. Or any other secondary infection, I'm sure during the admission probably covered with some antibiotic that he got better. I presume other tests was normal because thyroid you say is normal, so that's not the problem. And cardiac enzyme I believe is probably not too high, so there's no suspicious for ischemic heart disease as one of the cause.
Yes, and as we discussed, ischemic heart disease seems rather unlikely because the LV abruptly improved. And looking back on this man's notes, there was no fever that we recorded in the hospital, although he said he felt febrile. Okay, so let's go forward. So this brings us to April 2009, which is 3.5 years later. He continued to be well, sinus rhythm all the while. I stopped his ACE inhibitor, and as I remember, his blood pressure was always 90 to 100, always it wasn't really anything very much, and he had no complaint. And we had planned to stop his beta blocker. This brings us to February of 2010. This is 5 years after initial presentation. He came to the follow-up clinic and he said he had been well, but 2 weeks earlier he had experienced food poisoning for 3 days, and then he said he experienced some palpitation. When we examined him, he looked very well. The jugular vein was not elevated. There was no edema. Blood pressure was 90 systolic. Apex rate was 106, completely irregular. Lungs were clear. Abdomen was normal. The ECG showed atrial fibrillation, and there was no other morphological abnormalities. Just X-ray, normal size heart, clear lung field. So Dr. Koh, we're torturing you a bit today. What would your thoughts be about the diagnosis in this patient now? You've seen him 5 years ago, you carried him to a very stormy period, he had recovered, now something else is happening. Would there be any difference in your treatment of the patient this time around?
So, if I be following this patient, then I'll probably be clear that whatever initial trigger, like in this case, it's still triggered by something like food poisoning. So this gentleman probably has atrial fibrillation as a primary source from the beginning. It's a paroxysmal idiopathic atrial fibrillation, which easily triggered by any form of infection. But this time, of course, there's difference because hemodynamically, patient is well, whether it's physically with the BP is, I'm sure the BP is around this level, systolic 90, right? You were saying that the BP is always.
All while the clinic. Yeah, right. Yes.
Yeah, so the heart rate is not the big issue because the heart rate is not that fast. So I'll probably still start with the rhythm management, meaning that I'll probably going to initiate something like anti-arrhythmic drug like amiodarone, maybe orally for this patient and treat as outpatient, unless the patient has severe dehydration due to food poisoning, then I'll probably admit for further management. If not, just oral amiodarone, watch the liver function and thyroid function, and then we'll follow up back in the clinic and see whether he gets better or not.
Okay, thank you, Cole. So certainly I was less anxious about this man this time round as compared to his presentation 2005. But I was not brave enough like you to send him home. I said, okay, you better come to the ward for us to evaluate and treat you because you had a stormy period 5 years earlier. Renal profile was normal this time, as was the urine output. So we started him on oral amiodarone, as you said you would. We also gave him some digoxin with plans to switch to a beta blocker once the blood pressure was better. And for the first time, we started him with warfarin. We didn't have any of these modern day rivaroxaban or dabigatran in those days. And for the first time, I started thinking of tachycardia-induced cardiomyopathy due to atrial fibrillation as being a possible cause of this man's illness. So he remained well and he was discharged. 8 months later, he continued to be in. Sorry, I need to remove the mask. Yeah. Sorry. So 8 months later, continued to be in sinus rhythm. He had flipped into sinus rhythm during the first follow-up. Blood pressure was 100 by 80. ECG during this follow-up was a confirmed sinus rhythm. Echocardiogram was normal. So in June of 2011, he continued to be in sinus rhythm, but I was concerned that he might go back to atrial fib. So donidalorone had become available, and it was said to have a more safety profile as compared to amiodarone. So we started him on donidalorone 400 milligrams twice a day. In July of 2015, it's another 5 years down the road, yeah, he remained in sinus rhythm, but it was obvious during the clinic follow-up that his drug compliance was very poor. The INR was frequently sub-therapeutic. So the treatment that he was on at this time was digoxin 0.125, donidalorone 400 twice a day, and warfarin. So Dr. Choi, would you like to comment on the management of the patient thus far, also using experience in 2022? Yes, please, go ahead.
Okay. Well, my take is that up to this point, he has been very well managed. His EF is normal. He's actually quite fairly symptom-free. Medication-wise, has been helping him, that's for sure. That's a fact. But unfortunately, for this particular patient, as you can see, it's his compliance issue is the main hurdle. So whether or not he will actually continue taking his donidalorone or even his warfarin is quite debatable. Just a note on the donidalorone. Maltec donidalorone, this has been quite exciting back then. I haven't used it much myself. It's actually good for paroxysmal AF, but I think they have actually used the indication for those with persistent AF. So it means that if you have a patient who is more than just paroxysmal, donidalorone is not indicated anymore. So would I have done it differently if this patient were to present at 2022? I think knowing the fact that he probably suffered from tachycardia-induced cardiomyopathy, and we need to think about rhythm control, not just rate control. I will probably consider maybe catheter ablation for this patient at this point. This is the second time because I have a feeling that if we don't do anything to control his AF, especially during the fast AF episodes, knowing that he will probably stop his medicine, he will probably come in again with another stormy event. I don't know. This is my opinion.
Thank you, Toy. You're like a prophet as to what's going to happen in the future because now we can look backwards, all right? This is what exactly happened, what you predicted. So this March 2017, 12 years after the first admission and 7 years after the last known sinus rhythm, he came to the follow-up clinic. He had defaulted treatment and follow-up for 1.5 years. He had taken herbs. He said there was no complaints. Blood pressure was 100 by 80. Apex rate in the clinic was 78 per minute, regularly irregular, according to my notes. We did a 24-hour halter. Now, 24-hour halter is available. Non-sustained runs of atrial fibrillation. Echo and systolic function is good. So, Dr. Ko, what would you do now?
He departed clinic for so long.
Yes.
I just have a question. Why he suddenly come back to you?
He has left us off and on over the years, Ko.
Okay, so I will probably ask him, number one, about atrial fibrillation. You need to have the symptoms. If he claims that there's no symptom and is okay with the medical therapy, then probably I'll continue on. It's just that I also don't favor dronedron so much, nor amiodaron. We know that both have a lot of side effects. Then the next one will be beta blockers, which is probably kind of suitable for him because he had a history of low EF before. But the problem with beta blocker is it drops the blood pressure, and also what do you call it? It's not as effective as dronedron or amiodaron. Then the next in mind is whether the patient is suitable for other anti-arrhythmic drug, which is flecainide. Flecainide is the brand name is Tambocol. Now, flecainide can be used if the patient don't have any history of severe structural heart abnormalities such as myocardial infarction. Again, the patient don't have symptoms. I don't just treat the holter because the holter itself just show a non-sustained run of AF. I'll probably monitor as the echo is still okay. Unless the patient's really compliant and motivated, then of course AF ablation definitely has a role for him in 2022 because we know that any patient that we suspect has tachycardia-induced cardiomyopathy. This is the one thing that I need to emphasize. When we started this case, we never put the diagnosis of tachycardia-induced cardiomyopathy because it is always a diagnosis of exclusion. You see, all of us have to discuss what can possibly cause the AF, what can possibly cause the low EF. After we ruling all out, then we know that every time we control the rate, the EF become better. So hence the tachycardia-induced cardiomyopathy came forward. And of course, to prevent this from happening, the only thing is to remove the tachycardia, and we know that would be either catheter ablation or a continuous dose of antiarrhythmic, which is safe in long run, like flecainide. Secondly, when you touch about anticoagulation, what I need to discuss is during 2005, only warfarin was around, and it was probably the only choice. If now, looking back at this patient, I'll probably calculate the risk score, called the Chat-Best score, and see whether the patient has any of the risks. Let's say if the patient has a risk score of 1 and above, I have a low threshold of starting on the new oral anticoagulation because it is safe and more effective, I would say, than warfarin.
Thank you, Dr. Ko. So 2017, we were certainly more advanced as compared to 2005. So we did all the things that you suggested. We started him on low dose beta blocker. We used bisoprolol. And we also introduced anticoagulants. In this time, we gave him rivaroxaban because we thought that he was really very unreliable of warfarin. And this is certainly going to be more convenient. A year later, we did a stress echocardiogram, and this was normal. This brings us to January of 2019. So he was in the emergency room. For 1 week, he had gradual onset of effort dyspnea. For 3 days, he had paroxysmal nocturnal dyspnea. He again had defaulted treatment. He said he took our tablets only once every 3 days. This time he was breathless. Blood pressure was 90 by palpation. His apex rate was 140 per minute. He was in atrial fib. Lungs were clear to auscultation. EF this time had dropped to 10% again. If you remember that in between, his EF had completely recovered to normal since 2005. So a few questions to you, Dr. Koh. What would you do now? Would you perform electrical cardioversion immediately? What would be the success of electrical cardioversion in these circumstances? I think some of these have already been answered, but we'll just quickly go through.
So let's remove the EF aside. If you're looking at this patient with a symptom of heart failure, the BP is okay. To me, it's still quite stable. I'll always try medical therapy first rather than electrical cardioversion. But of course, with the luxury of having an echo in our CCU, sometimes we just screen, and if I see the echo is about 10%, probably I'm not going to do immediate cardioversion. I'll still do the usual way, a bit of IV digoxin or amiodarone to slow down the heart rate and see whether the BP improve further, the heart failure improve further. And also because we know that this history of patient, even at his worst time, he responded well to amiodarone. So I'll probably give amiodarone at this point of time. The success rate for electrical cardioversion is variable. I would say that most of the time, in acute setting, meaning that if you see the patient in sinus rhythm, suddenly the next day it turns into AF and you cardiovert almost immediately, the success rate actually is pretty good. But sometimes you don't know, this patient may have been AF for some time and then compounded by all this heart failure, EF is 10%. The success rate, I would say, is not very good. They will come back, as Choice mentioned, you can cardiovert, go to sinus rhythm a while, a few atrial topic, go back to atrial fibrillation. So I will probably not jump my gun and just cardioverse all patients with AF.
I agree. I mean, generally, our experience has been that if you have got an agent like amiodarone on board, your chance of getting them to a sinus rhythm and maintaining sinus rhythm certainly is going to be much, much better. Okay, so because of past experience with this patient, of course, he was certainly more ill again now. So he was admitted to the coronary care unit. He had dopamine to support his blood pressure. Amiodarone was given 300 milligrams over 1 hour. The blood came back, and again his liver enzymes were up, and there was some elevation in his CK enzyme. Thyroid profile was normal, but certainly the NT-proBNP suggested severe heart failure, measuring more than 9,000. 24 hours later, he was still in the AF, but the ventricular rate was better controlled at 100. BP was still low at 90. So I gave a little bit of digoxin for rate control. And this is 3 days later after admission. He was asleep in the middle of the night, and this rhythm appeared on the screen. It self-reverted. Dr. Koh, what could you advise us what this arrhythmia is? What are the possible causes, and what would you do?
Okay, so now let's look at this trip. There's probably 3 parts. Let's look at the first 1/3. Imagine you divide the street to 3 portions. The first 1/3 is a bit faded, but you can see that in general it's of course a tachycardia, a broad complex tachycardia. The first 1/3, the QRS complexes seem to be pointing upward, and then you can see that it becoming smaller, and And then the second point is like changing exit pointing downward, and then again it switches. So this means that this patient has, we call it a polymorphic ventricular tachycardia. So the diagnosis for this ECG is definitely a polymorphic ventricular tachycardia, broad complex, twisting of the point. There's a specific name for it. If it is due to long QT, it's called Tosa depot. Now, whenever you see this strip, it's very interesting. We will have to make sure, number of course, the differential is actually artifacts. Make sure the patient is not really moving during that point of time. Now, the patient is sleeping, so most likely it's a true rhythm. If it's self-reverted, most of the time there's a trigger causing this torsade. If it's not self-revert, means that this patient is already in a ventricular fibrillation. So I'm sure the next thing I will need to do is to look for the trigger. And I can tell you most of the time the trigger is almost always a long QT, and also the possible trigger is hypokalemia. These are very common trigger, especially in unwell patient, or hypermagnesemia. For me, when I see this strip, I would usually just give IV magnesium sulfate from the start, even without looking at any other thing, because IV magnesium sulfate has been proven to prevent the recurrence of polymorphic VT in the ill patient.
Okay, thank you, Ko. So that's what we did. We checked the electrolytes. The potassium was 3.8, the magnesium was 0.8, which seemed to be reasonable. The QTC was prolonged, and we looked back on the record. Amiodarone 600 milligrams total had been given the day before, and the ventricular fibrillation or the torsade occurred 1 hour after the amiodarone was completed. So what we did was stop the digoxin amiodarone and gave him carefully a small dose of beta blockers because, as you know, his blood pressure was lowish. At 10:50 that morning, he developed the torsade again. And this time, IV magnesium sulfate, IV potassium was given. And then I called for help and asked Choi from the EP service to help out. And Dr. Choi, at 1800 hours that same day, this is what happened to the patient. And maybe you can tell us what it was all about, what you did, and elaborate it.
Okay, thanks, Dr. Kannan. I think I can still remember this case quite vividly. So when I arrived to CCU, you know this telemetry screen, right? You can see a lot of these worm-like beats, touching, VF, then sinus rhythm, then a lot of episodes. So it was going into some kind of a storm-like polymorphic ventricular tachycardia. I think this is a very, he's a bit unlucky. I use IV amiodarone all the time, most of the time, in fact, for fast atrial fibrillation. I have to say that most of the time it works very well. Unfortunately, the Achilles point in using amiodarone is that, like what Dr. Cole mentioned, it kind of prolongs the QT sometimes. And coupled together with a little bit of hypokalemia, sometimes, you know, the patient can go into a torsade depot. In this case, I think that it's that contributed to his torsade depot. It was very persistent. So I gave IV magnesium sulfate, like what mentioned by Dr. Ko. That's the usual thing that we first do to stabilize the membrane so that the QT can be a little bit more stable. The second thing that we did was to correct the potassium, like to keep it a bit higher, maybe 4 to 4.5, that would be the better level of potassium. Sometimes we give many rounds of magnesium sulfate during an emergency. And for him, I think the torsade was quite stubborn and quite fiery. So I put him on IV lidocaine as well. So IV lidocaine is I think class 1B anti-arrhythmic drug. It can help in shortening the QT interval, and hopefully that will stabilize him. After the lidocaine, I think it was a bit better, but he was still having some short runs of VF. And given his unstable condition, I think we had a little discussion, I think with Dr. Kannan as well, together with the family, and they have decided to undergo a temporary pacemaker. So for those who are listening, they'll be wondering, why do we put in a temporary pacemaker? The patient is firing so fast. Do you need to pace the patient even faster? So the idea behind putting in a temporary pacemaker is that when you have a TOSA, it's usually because of the irregular rhythm that you get before the TOSA, the long and short RR intervals. When you have a discrepancy of the RR intervals, then your QT interval will also keep on changing. And when you're unlucky, when you have a pause after a PVC, all right, the QT will be long. And if you're unfortunate, you get another PVC after the pause, and the PVC may land on your T. So that's when you get the RNT and you get a TOSA. So the basis of putting a TPM or temporary pacemaker is for us to overdrive. So we pace the patient at a higher rate, like maybe 80 or even 90 beats per minute, not giving chance to the patient's PVC to come out. So we take over the patient's rhythm. So we pace it high. And this is what we call overdrive pacing. And you can see the second picture in the middle. So that's actually a pacing rate. So once we started overdriving the patient, the TOSA became very dormant. It failed to come out because it cannot initiate the TOSA anymore. So that was what we did that day.
I'm going to speed up this discussion quickly so that we can get to see the next case, which is Cole's case. So basically here, the first strip shows that he had TOSA, he had to be defibrillated, then went to sinus rhythm, and then the second strip shows the pacemaker that Choi implanted temporary pacemaker, and he's being overdrive paced. So I will just go quickly through this so that we have time to discuss more, yeah? So this man ended up having a DDD ICD implanted on the 16th of January 2019 with the AICD in place. He was having breakfast. He had another run of TOSA, but this time he had the AICD. This defibrillated him successfully without him even realizing. And a small dose of beta blocker was started on the 18th of January 2019, which is 9 days after admission. This very sick patient was walking about the hospital, and the 28th of January, his EF had improved to 35 to 40%. By April, his EF had normalized. Finally agreed to have a CT angiogram done in March of 2019, which showed that he did not have any coronary artery disease, and his problem was all atrial fib and tachycardia-induced cardiomyopathy. Last follow-up was on the 21st of March 2022. He told me that he had finally learned his lesson. He was now compliant with medication. Blood pressure was 100 by 80 during this visit. Pulse rate 68 per minute regular. I think Choi told us that review of his AICD revealed that he did not have any atrial fibrillation episode in the last 2 years. His medications now were bisoprolol, flecainide, and dabigatran. With that, I think we'll go on to Dr. Koh's case. Sorry, just before that, to just show the echo of his first patient. This shows you initially very poor LV function. You see there's hardly any contractility. 20% is what we measured. And the second set of echoes is after it's recovered. You can see that left ventricle is squeezing away. It's always very gratifying to see something like this.
Yep.
Okay, let's go to case 4, which is Dr. Koh's case. Dr. Koh will present.
Okay, maybe let me just breeze through how would I approach a case of atrial fibrillation when it comes to me. So I have a privilege to meet this man, a 65-year-old company director, about almost a year ago. This is his first presentation to the hospital in July 2021, where he told me that he had always been well, exercising, eating healthily, but then suddenly he had this a weak history of dyspnea at rest, autopnea, lethargy, but there's no complaint of angina. And the patient, when comes in, the BP is borderline 100/60. The pulse is rapid 120 and irregular. So clinical diagnosis is already atrial fibrillation. Has a bit of raised JVP, some heart failure signs and symptoms, no fever. Next slide, please. So you can see that the ECG shows something. Choi, do you want to add anything on the ECG?
No, I think it's a very clear-cut AF with a rate of 143. So we need to control the rate. Maybe you go ahead because we are running out of time.
Okay, sure. So the ECG show AF, fast heart rate, a bit of left ventricular hypertrophy signed by voltage. That can be due to hypertension or even underlying cardiomyopathy. Yeah? Now, of course, the echocardiogram immediately shows the EF of 20%, globally hypokinetic. I just want to make sure there is no severe MR or severe aortic stenosis causing the problem. Then the first step I will do, usually, as I mentioned, conventionally, I'll give IV amiodarone first. The usual loading in a normal weight person, I will give 300 milligram bolus. Watch the heart rate. If not getting better, then I will just continue follow up 900 milligram of amiodarone over the next 24 hours. The patient's converted to atrial flutter. I thought it's going to back to normal rhythm, but eventually it get back to atrial fibrillation. It's quite resistant. Only I think about 48 to 72 hours of IV amiodarone, only it get back better to normal rhythm, the heart failure better, and coronary angiogram was performed to make sure there is no severe coronary disease, and all three vessels appeared to be mildly diseased. Next slide, please. So he was discharged on amiodarone. The heart rate is a bit irregular, seriously in AF when they discharge. Is on the Lipitor for the mild coronary disease, bisoprolol for rate control, and dabigatran 150 milligram BD. At this point, his chatbag is about 1 because of poor EF. Sacubitril valsartan, the brand name is Entresto. We use for patients with heart failure, and also spironolactone is used for heart failure. Now, good enough for him. During about 1 to 2 weeks follow-up, the ECG actually came back with a sinus rhythm. So the amiodarone did its work, converted finally, and the blood pressure is about 110/60. So he cannot tolerate a higher dose of bisoprolol due to giddiness. The dose of bisoprolol I aim actually to 10 just to improve the heart function, not for the AF. But the patient still complaining troubled by a short burst of this palpitation, most likely due to the paroxysmal atrial fibrillation. Just by rate control and rhythm conversion, the echocardiogram EF improved within a few weeks to about 40%. He don't have any breathlessness. The only problem is the palpitation. So next slide. And the ECG, you can see that is sinus rhythm, but a bit of irregularity. Now, all these irregularity, yes, as pointed out by Dr. Kannan, these are actually bursts of premature atrial complexes, or we call it atrial ectopics. And we know that most of the atrial fibrillation are triggered by these atrial ectopics. All right. Now, I can convert to sinus rhythm, but I cannot remove the atrial ectopics completely, which actually causes the symptoms. Next slide. Looking back, the rapid improvement, like Dr. Kanan's case, is almost the diagnosis of AF-induced cardiomyopathy or tachycardia-induced cardiomyopathy. But the patient remains symptomatic. So I just want to open up to Dr. Kanan and Dr. Choi. What's the next step? Let's say we are given 4 usual options. Either we reassure the patient and tell the patient to live his life with the symptoms, since everything else is improving, or we want him to just increase the amiodarone to control the symptoms, or maybe change to flecainide. Don't use amiodarone, don't use beta blocker. Flecainide sometimes works well with atrial ectopics, or maybe perhaps we go straight to atrial fibrillation ablation. What do you think, Dr. Kanan, Dr. Choi?
To reassure the patient and tell the patient to live with the symptoms, I think it will be a bit tough. Hopefully, having palpitations every day. Now, amiodarone, the higher the dose, we also worried about side effects, both in the short term and particularly in the long term. And this is something going to be needed for a long time. Now, flecainide, I don't think I'll be brave to use because its LV systolic function is already reduced, so it's structurally depressed heart. So I think from what you have told us earlier, I mean, this is a candidate for ablation because basically medical therapy has not controlled him.
Yeah. So if I may add, I totally agree with Dr. Kannan as well. I think all the above except the D, atrial fibrillation, will be less appealing given the fact that he's a high position in his company. I had a couple of ectopics once and I felt very uncomfortable. So I think it's very difficult to just take drugs for life, be dependent on it. Just if I may add 1 more minute just for our listeners' sake, we all talk about PAC control and atrial fibrillation. I had a GP friend who asked me before this very basic question: why do we need to address the PAC in terms of ablation to prevent AF? If I can just use the concept of a lake, if you imagine that our heart is like a very peaceful and calm lake, and we only have one person throwing a pebble into the lake at the same time, and that person is called a sinus man. So you're throwing a sinus rhythm, beat by beat, in a very controlled fashion. And one fine day, he realized that there's another guy next to him throwing another pebble, but in a very bizarre rate. Okay, fine. Now you have two ripples. And then after a while, you realize that, oh my God, the lake is getting more and more crowded. More and more people are throwing pebbles into the lake. And one of these days, one fine pebble will just go into the lake and start a non-stop and bizarre and rippling effect of the whole lake. You can look at the lake and it's all rippling. So that's the concept of atrial fibrillation. So I think if you go for ablation, it's fundamentally like a fencing of all the other fellas, So no matter how many pebbles they try to throw into the lake, the pebbles will not reach the lake, and leaving the only guy, the sinus guy, back into his own business. That's the only thing I would like to add. That's why I go towards atrial fibrillation ablation for this guy.
Very nice, nice explanation, Troy.
Yep. In fact, I actually put all the option A, B, C, D on the table and discuss each one with the patient because patient is very educated. He's a company director. Everything I did, if you think you can take option A, go ahead. You can live with it. Increase amygdala, if you're not too sure which to choose, you can try, but I told him not for long-term side effect. Flecainide, a bit dangerous if the EF is a bit low, but I think it's still safe, but we need to monitor closely, or atrial fibrillation ablation. So next slide. So my thought and discussion, since the AF is the culprit, that the eliminating the AF would be reasonable. And you saw the previous ECG, I saw the guy that throws the pebble. So it's easy for me to shoot the guy with a pebble rather than wait too long and too many guys need to be shot down later. So I think this patient is still very early phase in the atrial fibrillation. Sometimes it's very easy to catch. Medical therapy is limited, as we have extensively discussed. And actually, atrial fibrillation ablation per guideline is indicated for symptomatic relief of atrial fibrillation that fails medical therapy. The only thing that I need to discuss further so that the patient understands that is AF ablation is safe, but the rate of maintaining, the success rate of maintaining sinus rhythm is about 70 to 80%, especially if it's done in early years. So what happens if it recurs? Then you need to go for second ablation. And actually, it's quite pretty common in all over the world. If you go to Singapore, Taiwan, Australia, US, UK, when they do all this atrial fibrillation, it's not uncommon for patients to come in for a second atrial fibrillation. This is something that the population and other doctors need to understand. It seems like a coronary disease. If you put a stent there, it doesn't mean that you no need to stent for the rest of your life. You still probably need to repeat angiogram and maybe a PCI. The important thing is the new data have come out in 2020 that AF ablation itself, if you control the rhythm early and successful, is able to prevent the AF related complication that what have been presented earlier by Dr. Kannan's case and my case, which is you stop the heart failure. You even have a benefit of stroke reduction despite your patient on anticoagulation. You still have a bit of improvement and reduction in stroke prevention. So these are my thoughts. So that I told the patient. And next slide. Of course, the patient itself, own words, he told me that he cannot focus actually because of the palpitation. he is a company director. He need to make a lot of decisions, and he said that even that he has 50% chance of cure, he will try to go for it because he cannot imagine for the next 20 years living with atrial fibrillation, always worry about risk of stroke, admission, and also bleeding with NOACs. Now, how do we do AF ablation? Very, very simply, I just put it. You can see the diagram on the left side, which I have drawn out all the 4 pulmonary vein, the left superior pulmonary vein, inferior, right superior. Most of our trigger, the guy that throwing the pebble, reside in one of the vein, more than 90% of the time. If we able to isolate all the vein, when I say isolate means that we are putting a catheter, this is a catheter, touching on the wall of atrium, and we do something like a bit of radio frequency microwave kind of ablation, in the simple term, welding of the tissue. Now, all this tissue, it causes a bit of scarring so that it won't conduct electrically from the vein into the atrium. When we're able to isolate all these 4 veins, on the right side, which I did for this patient, this is a real image of the patient. You see all these dot, those we ablated. We isolate the whole vein. Then the guy that throwing the pebble cannot even throw because they're no longer able to connect to the atrium. Now, with this, the patient done ablation in November, now it's almost 6 months, no recurrence, touch wood, and patient feel very well. That's the first thing he mentioned. No more palpitation that troubles him. And he's very happy for that. And we slowly taper down the medication, and the EF actually improved even further. I'm not too sure whether you include the EF or not. Can you show the slide, please?
Okay. In the interest of time, we will. These are your pictures.
Yeah, I just want to show that. You see the first picture, EF is poor. Then later on, the EF slightly improved. You see the LA size becoming smaller. Dr. Kana, you can show the LA size from the first one, second one smaller, and then become even smaller. So that's called remodeling. If you do it in the very early phase, this result will be good. But on top of course, medical therapy for heart failure, if you see this patient is treated very aggressively initially with heart failure medication, now able to slowly reduce the medication for this patient.
Okay, we'll move on quickly to try to get the last 2 slides so the messages are through. So to keep things in perspective, Dr. Choi and co, we have just discussed 2 patients with tachycardia-induced cardiomyopathy. How common is this in patients with atrial fibrillation? First question.
It's not very common, to be honest, but on and off we see that maybe out of 20 to 30 AF patients that we see, one have impact heart function. The only problem is whether we can call it a tachycardia-induced cardiomyopathy, or the patient have underlying cardiomyopathy, then develop AF is the dilemma of chicken and egg theory. So not very common, but we do see on and off.
So quickly again, next question. What are the important indications for radiofrequency ablation in patients with atrial fibrillation?
Now, Choi?
Yeah, I think traditionally it's all about heart failure. If your AF cause heart failure, I think the indication is very strong. Second will be symptom. I would say if the patient is very symptomatic, whether it's from the high PAC burden or the AF itself. If I can just use 30 seconds to explain one case of mine. So I remember very vividly this patient who came. He has been living with AF for I think 3 years. Actually, seen a couple of doctors, and traditionally I was taught that way as well. When you see AF, you got no symptom, just leave it alone. So he came in the hospital because he had an upper GI bleed, and because of that, they referred to me for a very fast AF. And to cut things short, after a couple of months of monitoring him, he decided that, okay, you know what, you have spent so much time on me, so I would say we go for ablation. So I did a cryoablation for this patient, and he went back to sinus rhythm. He has been about 6 months now. He's actually sinus rhythm. And he told me one thing, this is his own words. He said, although I did mention that I was not having any symptom when I was suffering from the atrial fibrillation, I have to tell you now that I feel so much better. I can run more. I can go up all kinds of hiking hills. All right. I feel good because it's, there's only one man throwing the pebble now, okay? There's not much of a rippling effect. So my take is that sometimes when the patient tells us that they don't have symptoms from a very chronic and stable atrial fibrillation, that is quite subjective. So we probably have to dig in a little bit more for his symptoms or do more tests before we say that their patient actually not symptomatic. Yeah, just to add in this point.
Okay, quickly, I think we have run out of time. So just give some take-home messages for the audience from our part 1, part 2. Atrial fibrillation is not benign. It's a chronic progressive disease. Rate and rhythm control prevents and can reverse cardiac remodeling. Anticoagulation therapy is important patients selected according to set criteria. Rhythm control early in the course of atrial fibrillation confers mortality and morbidity benefits to patients, and selected patients, radiofrequency ablation enhances maintenance of sinus rhythm. Thank you and happy Vesak to those of you celebrating. Okay,
Thank you, everyone.
No?
Thank you.
So far, no questions.
No questions.
So far,
Everybody wants to go for a long weekend.
Checking so far, nobody. Very clear, crystal clear.
Thank you very much,
There have
everyone.
been no questions. So, yeah, none in Slido, none in YouTube comments either. So, everybody is enlightened.
Enlightened.
In Visa Day, it's Visa. So everybody is very enlightened. Okay, just let me go down to
So we have some time, is it?
We are actually just past 3. We overshot a little bit.
Okay.
Yeah. So I think for those who want to claim their CPD points, they can scan this QR code now. Let us know if you have successfully scanned the points. Now, for those of you who are new to the stream, just want to share that you can actually view our past grand rounds at this site. I'll type it down for you. You just go to bit.ly/SJMC Grandrounds. Okay, I'll just show it now. So bit.ly/SJMC Grandrounds, and you'll be able to see not just this video, but also all our past Grand Rounds streams. Okay, so you can catch up with part 1 of the atrial fibrillation webinar and others. We've done 18 others, and this is number 19. Okay. All right. Any other comments? All managed to get your points? Yep, worked for me. Good. Excellent. Thank you. So thank you, everybody. Have a happy long weekend. Happy Vesak to those who are celebrating. We're all very enlightened now on atrial fibrillation. Thank you to Dr. Kanan, Dr. Choi, and Dr. Koh for the excellent presentation. And we'll see you again. There will be none for June, so I'm reminded. So we are taking a break in June. we'll start again, which is actually the start of the next CPD cycle, which will be in July. So I hope you all got your compulsory points, 20 points, because you've got to get this by 30th of June. So all the best. So there are lots of avenues to get them online in case you haven't got enough points, okay? And do seek help with your colleagues if you are still struggling, okay? All right. So good afternoon and have a good weekend.
Good weekend.
Yeah, right.
Oh, good. Thanks, Alan. That was good.
Thanks. Thank you, everyone.
You think I'm very busy because of National Heart.
National Heart, they got